My dear students, in this video, I am going to discuss some points about the PKPD of antibiotics and their importance while choosing and prescribing antibiotics in the ICU. This is very important for the simple reason that whenever we choose an antibiotic based on the antibiogram, the PKPD finally determines whether that antibiotic achieves its action at the targeted site, whether it achieves in sufficient concentration in which that action is required at the targeted site, and finally, whether this antibiotic needs to be administered in a bolus or infusion or extended infusion so that it can attain that power to cure that infection at the targeted site. So, antibiotic selection in ICU is not an easy task. It is complex. And this complexity arises because of number of reasons. One, because of rapidly changing patient physiology, because of evolving resistance ecology based on the use of antibiotics in any particular ICU, depending upon the high stakes of urgency, that is the severity of the infection and its likely impact on the various organ systems, and because of limited pharmacological predictability, because of this alteration in the internal milieu, how much that antibiotic will be able to achieve in the action, that is also becomes unpredictable. Therefore, when we choose an antibiotic, it is not just about choosing the right drug. It is also about choosing the right drug in the right dose at the right site, at the right time in the right patient. And whenever we look into each of these domains individually, then we can further elaborate on why it adds to this complexity. Like altered PKPD or pharmacokinetics and pharmacodynamics makes the drug levels unpredictable. The MDR pathogens which are common in the ICU makes empiric coverage difficult. Diagnostic delay can result in catastrophe, and therefore many a times needs empiric therapy without sufficient data. Site penetration becomes a variable efficacy, it changes. Organ support changes the clearance of the drug. So whenever a patient is on RRT or ECMO, the effect of antibiotic also changes because the PK changes, so the PD also is affected. Host comorbidity modifies drug metabolism and immune response. So that in effect influences the antibiotic. Local resistance is important. So someone who is ignorant, who lacks the knowledge of the antibiogram that is prevalent locally, is unable to choose the antibiotic. The stewardship balance, while choosing the antibiotic which is most likely to be useful in that scenario versus the chances of the bug becoming resistance in the long run for that infection to that antibiotic, needs to be balanced. Biofilms are important, and whenever biofilms are created, they give a protective shield by a polymeric substance around the bacteria, which the antibiotics are unable to percolate. So therefore, we need antibiofilm antibiotics and therapeutic drug monitoring, because therapeutic drug monitoring, although it is available only in very few centers, but it is highly resource intensive and it adds to the cost. So it is not available always. As we know, pharmacokinetics means what the body does to the drug. So whenever a drug is administered, it is absorption. Absorption is often irrelevant for IV antibiotics in the ICU because almost 100% is bioavailable, but it is crucial for enteral agents like oral fluoroquinolones if they're used. Then is the volume of distribution, that is, which reflects the extent the drug dispersion in the body compartments. Whenever we administer a drug, initially it is in the blood, which is the central compartment, and then it spreads to the peripheral compartment, which are the peripheral tissues. Now, depending upon whether it is hydrophilic or lipophilic, the drug either stays or leaves the central compartment And even when it is leaves the central compartment, its penetration into the tissue is determined by its lipophilicity. So the distribution is also important. Metabolism, some drugs are exchanged unchanged in the urine, or they are converted into some blood products which are exchanged renally, and some are metabolized in the liver, for example, macrolides and the linezolid. And finally, the excretion or elimination, which is largely renal for beta-lactams, aminoglycosides, and vancomycin. So any alteration in the renal function is likely to affect the elimination of such drugs which are dependent on the kidneys for their elimination. So pharmacokinetics describes the time course of the drug concentration in the plasma and the tissues, and that defines its action. The pharmacodynamics is what the drug does to the body. So in this particular case, it will be what the drug does to the organism. Since it is an antibiotic, it is bound to have some, or expected to have some action on the on the microbials. So some drugs, they are concentration dependent. That is, the Cmax, or the maximum concentration attained in the plasma by MIC, that is the minimum inhibitory concentration, determines their killing effect or Seidel effect. And the higher we are going to raise it, the more likely the drug is likely to have its effect, like the aminoglycosides and fluoroquinolones. Some drugs, it is have both concentration and time dependent action, and in for them it is the area under curve by MIC, minimum inhibitory concentration, that determines their effect or their efficacy. Like the fluoroquinolones in higher doses, it shifts from Cmax by MIC to area under curve by MIC. And these drugs some of them may require a loading dose also. The third category of the drugs are the time-dependent drugs, on which their action depends on the time for which they remain above the level of the MIC, or the minimum inhibitory concentration. So such time-dependent killing actions of the drugs, they also require extended infusion. So only by extended infusion we can ensure that the concentration remains above the minimum inhibitory concentration. Therefore, pharmacodynamics links drug exposure to the antibacterial activity. So you have to also remember that whenever we administer the drugs, it is not only the MIC that is going to serve the purpose. There is another concentration above which we expect the drugs to act, to retain, because at that level, the mutant production or the concentration is less. So that is called the MPC. So if a drug remains for a long time between the MIC and the MPC, so that window is actually determines how quickly or how efficiently the bug is going to acquire resistance to that drug. So this MPC is much above MIC, but we also don't want that or we should plan the dosing to a way that this time, that is the TMSW, that is the mutant susceptibility window, should be kept to minimum. And this is likely to be minimum with drugs which have a concentration dependent killing mechanism, where we target the Cmax instead of T greater than MIC or area under curve greater than MIC, as you can see. So whenever there is bolus infusion, this TMSW, or the time of mutant selection window, is reduced. Whenever we go for extended infusion, no doubt that the time dependent action of the drug increases and it kills, but at the same time it also confers the organism some guide to become resistant to that drug. So in managing antimicrobial resistant infections, the focus often shifts from MIC based to MPC based indices to ensure effective therapeutic outcomes for the long run. Now, if you look into the common antibiotic classes and try to identify their PKPD, describe their killing pattern, cite examples, and also tell the optimal strategy, it will be optimization strategy, it will be possible for us to see the differences. Mostly for beta lactams, it is the time over minimum inhibitory concentration that defines their action. So they are time dependent. For example, the peptides, meropenem, cefepime, etc. And the optimization strategy would be always to prolong or continuous infusion. Aminoglycosides are concentration dependent, whose PKPD target is achieving the Cmax by MIC, and they require high peak once daily dosing. In fluoroquinolones, glycopeptides, oxazolidones like the linezolid, all of these are area under curve over MIC as a target. Some of them are concentration dependent like the fluoroquinolones and the polymyxins. Some are time dependent like glycopeptides and oxazolidones like the linezolid. But still, the PKPD target remains the same for that. And therefore, some of them would require adjustment of their dosage according to the for achieving the high area under curve. So, and some of them would require loading dose in addition to the maintenance dose. So, what pathological alterations occur during critical illness that can cause these differences? One is the increased volume of distribution. Whenever there is a critical illness, particularly there is the inflammatory system is activated, there is capillary leak, there is and also there is aggressive fluid resuscitation, there is hypoalbuminemia. So all the hydrophilic drugs, they become distributed more widely. Normally the hydrophilic drugs stay in the central compartment, but because of increased capillary leak, aggressive fluid resuscitation, they're pushed outside, and therefore their concentration in the blood is reduced. So in septic shock, standard doses of meropenem may not reach adequate level in the plasma or in the intestinal levels because of that distribution. Second is altered drug clearance. In altered drug clearance, augmented renal clearance is a condition which occurs in young, septic, post-trauma patients with high cardiac output. And therefore, despite giving a normal dose of beta-lactam or vancomycin, these patients, the blood levels can become subtherapeutic. Next is the renal impairment or in renal replacement. There is reduced clearance, so there can be accumulation and drug toxicity, which requires dose reduction or post-dialysis supplementation. That is, after dialysis, we administer the full dose. Next is the hepatic dysfunction. This impairs metabolism of drugs that are metabolized in the liver, macrolides, linezolids, fluoroquinolones, etc. The next important thing that affects the drugs are the protein binding alterations. Hypoalbuminemia increases the free drug of the highly bound antibiotics. We know that the free drugs are responsible for the action, and free drugs are also responsible for the side effects. Therefore, the effect of free drug needs to be understood in the context of the reason for which it is being used. There, an increased clearance may offset the apparent benefit by virtue of causing toxicity on account of its free drug. The effect of hypovolemia, there are certain drugs which are lowly bound, certain drugs which have moderately bound to albumin, and some drugs are highly bound to albumin. Examples with minimal binding or low binding includes aminoglycosides, beta-lactams, etc. Moderate binding includes vancomycin, tigecycline, etc. And market binding or high binding is seen with drugs like ceftriaxone, artepenem, teicoplanin, cefazolin, etc. So in those drugs which are low bound to hypoalbuminemia, to bound to proteins, hypoalbuminemia, there is no dosing changes needed. But however, the effect of hypoalbuminemia on the drugs with intermittent binding will affect minor adjustment in extreme hypoalbuminemia. And for marked effect, there can be altered dosing or dosing based on therapeutic drug monitoring. So measuring local concentrations like vancomycin, ceftriaxone, etc. may either underestimate or overestimate drug exposure in hypoalbuminemia. So what are the mechanistic effects? So whenever there is increase in the unbound fraction, if the total albumin drops, for example, 3.5 grams per deciliter to 1.5 grams per deciliter, less drug can bind. So the free unbound fraction increases. Initially, the total plasma concentration decreases, but free concentration may remain therapeutic or it may even rise. For example, ceftriaxone is normally 95% bound, so unbound fraction is only 0.05. In severe sepsis, the binding drops to 80%. So unbound fraction increases almost 4 times from 0.05 to zero point 0.2. The increased volume of distribution, as I said, also affects changes because the free drug that diffuses more readily into the tissues and the expanded extracellular fluid because of capillary leak or resuscitation amplifies this. So there is an increase in the apparent volume of distribution and there is also a fall in the plasma concentration, even though the total dose may remain the same. This effect is most pronounced for hydrophilic, highly protein-bound antibiotics like ceftriaxone, ertapenem, daptomycin, etc. Next, there is also an effect because of increased clearance for renally eliminated antibiotics, since only unbound drug is filtered or excreted by the kidneys. And we know that the clearance in the kidneys is the product of the unbound fraction multiplied by the glomerular filtration rate. So it is natural to understand that whenever there is a higher the unbound fraction, there is higher clearance. Hypoalbuminemia accelerates elimination of the free fraction, but as the clearance rises, total plasma concentration may decrease. So this may mislead clinicians into thinking that the drug is subtherapeutic. Actually, it may not be so. For example, if you see free meropenem or cefepime, it is clearly rapidly eliminated in the sepsis with augmented renal clearance, even though the measured total levels may remain low. So altered hepatic clearance is also have an effect for hepatically metabolized drugs. There are two groups of drugs, some with a low extraction ratio and some with for high extraction ratio. So only unbound fraction is available for metabolism in the category with low extraction ratio drugs, and increased uh, fraction, that is a fraction can increase the hepatic metabolism if the liver function is unbound fraction can increase hepatic metabolism if the liver function is preserved. For high extraction drugs like the erythromycin, clearance depends mainly on liver blood flow and less on protein binding. So this remains unchanged. So if we look into the overall effect of hypoalbuminemia on the key antibiotics, we can see that primarily for ceftriaxone, ertapenem, cefazolin, etc., the levels increase, and the clinical consequence would be, in case of ceftriaxone, a reduced total level, faster clearance, possible treatment failure in sepsis or in meningitis. In cefazolin, there is increased renal clearance, subtherapeutic, unless doses are adjusted. Likewise, with cefepime, vancomycin, daptomycin, colistin, linezolid, there are variations in their consequences based upon the albumin level. Next is the tissue penetration issues. When there are poor perfusion, that limits drug delivery to the infection site, and the lipophilic agents penetrate tissues better, and those which are hydrophilic penetrate poorly. So the net result of effects in the ICU can be very broadly categorized in three cases. Case one, there is low albumin and normal renal function, in which there is an increase in the unbound fraction, increase in the volume distribution, and increase in the clearance, but there is reduction in the total plasma clearance because the fluid has escaped from the central compartment, which is the plasma, to the peripheral compartment. But free concentration may be adequate or subtherapeutic depending upon the clearance, even when the total plasma concentration is reduced. The second scenario can be one where there is low albumin and there is renal dysfunction. Here also the unbound fraction increases, but clearance is reduced. Free drug accumulates. Toxicity risks exist with ceftriaxone, which is ceftriaxone encephalopathy, or if the patient is on valproate, there can be valproate toxicity. Third case, there is hypoalbuminemia plus augmented renal clearance. Here also there is an increase in the unbound fraction with increase in the renal clearance, and severe subtherapeutic exposure occurs despite standard dosing. Now the important thing is, why is loading dose so important in the ICU? In ICU, patients reaching therapeutic levels quickly is very vital, because any delay in attainment of target concentration correlates with a higher mortality. Standard doses are based on stable pharmacokinetics, and they are often studied in healthy volunteers. So they often underestimate the expanded volume of distribution which is seen in critically ill patients. And many antibiotics have short half-lives and time-dependent killing, making them early target attainment possible. So always give the loading dose first, regardless of the organ function. The principle is vital, especially for septic shock, meningitis, endocarditis, MDR infections, and also in CRRT or ECMO patients. There is a mathematical basis by which you can calculate the loading dose, which is nothing but the product of target concentration and the volume of distribution. This is critically important in critically ill patients. If the volume of distribution increases due to the sepsis, fluid resuscitation, or hypoalbuminemia, the required loading dose also increases. The loading dose is generally not altered by renal or hepatic function, because it is meant to fill the volume, not depend on clearance. Therefore, the key points on this, that maintenance dose is clearance dependent, whereas loading dose has to be distribution dependent. Let us look into the clinical examples. Beta-lactams, they are hydrophilic and time dependent. Beta-lactams are highly affected by increased volume of distribution. Let us take piperacillin tazobactam, for example. The standard dose is 4.5 grams every 6 hourly. In septic shock, the loading dose of 4.5 grams IV is given over 30 minutes, followed by a continuous infusion of 13.5 to 18 grams over 24 hours. The rationale is that the rapid attainment of concentrations, which is 4 times more than MIC, ensures optimal time that the concentration remains above MIC. Example, meropenem, if we give a loading dose of 2 gram followed by a maintenance of 3 grams over 24 hours, it can achieve the same concentration that is required. Or we can also give 2 grams 8 hourly as an infusion after the loading dose of 2 grams. In case of colistin, colistin is given as cholistimethate sodium, which is an inactive product that slowly converts to active colistin. So therefore, it is recommended that 9 million international units is administered IV over 1 hour, followed by 4.5 million units 12 hourly, and adjusted for the renal function. So the rationale again is that rapid attainment is crucial for MDR, Acinetobacter, or Pseudomonas infection. Aminoglycosides, we know that it is a concentration dependent with post-antibiotic effect. The loading should ensure sufficient concentration, and usually the loading ensures a concentration or Cmax by MIC ratio of more than equal to 10. Let us take the example of amikacin. The loading dose has to be 25 to 30 mg per kg ideal body weight. Monitor peak levels between 20 to 40, and if the volume of distribution is expanded, like in patients with septic shock, burns, etc., it may require even higher loading dose. Let us see a step-by-step calculation in a 70 kg patient with septic shock and ARDS started on CRRT for AKI. The empiric coverage with meropenem and vancomycin is planned. So with vancomycin, we know that we have to keep a target of 4 to 5 times the MIC to maintain its time-dependent action so that at least 60% of the time between the intervals, it remains above the MIC. So target MIC being 4 to 5 times the MIC, and if we assume an MIC of 8, the target has to be 32. The volume of distribution is 0.4 liters per kg, because which can increase to 0.6 per kg in patients with sepsis. And then we calculate the loading dose, that is multiply C1 into volume of distribution, that is 32 into 0.06 multiplied by 70, and it is around 1344. So you have to remember that always admit, if you calculate the meropenem now, you see that the total dose is around 1.5 grams is the loading dose. So administer 2 grams loading dose as a round cap and continue infusion. Vancomycin, the target is 25 mg per liter. The volume of distribution is 0.9 liters per kg, and the loading dose should be 25 multiplied by 0.9 multiplied by 70, so 1575 milliliter mg. So administer 1.75 gram loading dose, or we can also then adjust based on TDM. So practical approach to loading dose in the ICU: piperacillin tazobactam, we give 4.5 gram bolus, meropenem 2 gram bolus, ceftazidime 2 gram, vancomycin 25 to 30 milligrams per kg, amikacin So these are important. In vancomycin, it is 25 to 30 milligrams per kg. In amikacin also it is the same. Colistin, it is 9 million units with containing 300 milligram base. Linezolid, it is usually 600 milligram in twice a day. If it is enteral, routine loading dose is not required if the drug is administered IV or in oral. And daptomycin, it is 8 to 10 milligram per kg, although higher dose is required for endocarditis, bacteremia, etc. In addition, we have to look for the loading dose in certain specific scenarios like augmented renal clearance, renal replacement therapy, and ECMO. In augmented renal clearance, only maintenance doses needs upscaling. ARC increases elimination, so loading dose remains unchanged. In renal replacement therapy, RRT can remove antibiotics during early hours. So loading dose should never be reduced in CRRT. Start with a full dose to saturate the body compartments. For example, meropenem 2 gram IV loading dose is followed by 1 gram 8 hourly during the CRRT. ECMO, extracorporeal circuits absorb lipophilic and protein-bound drugs. So administer full loading doses, sometimes higher, to compensate for the sequestration. There are certain pitfalls, and one should have some cautions, like do not skip the loading dose because of renal dysfunction, avoid excessive loading dose without monitoring, watch for dilutional effects, and therapeutic drug monitoring is the safety net. So always recheck plasma levels within 24 hours for narrow therapeutic index drugs. Let us go through a few more cases. A 50-year-old man with septic shock due to intra-abdominal sepsis started on Piptas 4.8 8 hourly. Despite 48 hours of therapy, clinical response is poor. Blood culture grows Pseudomonas aeruginosa with MIC of 8. Explanation is that due to high volume of distribution and capillary leak, plasma concentrations never stayed for more over MIC for more than 50% of the dosing interval, and this was the reason why it didn't work. So we have to switch to continuous infusion after a loading dose, like 4.5 gram loading followed by 13.5 grams over 24 hours in infusion. And if therapeutic drug monitoring is available, they can ensure steady state concentrations to maintain the MIC of more than 4. So let us look into this case. Case 2, a 25-year-old polytrauma patient with VAP receives 15 milligram per kg amikacin. Peak level at 1 hour is 12 milligram. MIC for Klebsiella is 4 milligram. So the explanation is that we have to look for a Cmax over MIC of 3 because 12 divided by 4 is 3. And this will be a subtherapeutic. So the target has to be 8 to 10. So this is because of augmented renal clearance. So we have to increase the dose from 15 milligrams per kg to almost twice, that is 25 to 30 milligrams per kg, and recheck the peak levels. And augmented renal clearance patients may require 30% to 50% higher aminoglycoside dose. Also, you prefer extended interval dosing to exploit concentration dependent killing and minimize toxicity, although it may not work always. Next case is a 65-year-old with MRSA pneumonia who develops AKI on the background of kidney disease requiring CRRT. Vancomycin 1 gram 12 hourly yields random levels, which is 35 milligram per liter, which accounts for the toxicity. So lesson is that the vancomycin PK is altered in CRRT. Clearance depends on the effluent rate, and the should be target area under curve by MIC should be 400 to 600. So we have to use TDM guided dosing and consider Bayesian software to personalize the dose. Let us look into this case 4. A 70-year-old with multi-drug resistant Acinetobacter started on colistin 2 million units 8 hourly. Pitfall is that colistin is a prodrug that requires conversion to its active form. Its PK is complex with delayed attainment of the steady state, which usually takes 2 to 3 days on average. And optimization, that is administer a loading dose that is 9 million units followed by the maintenance, that is 4.5 million units over 24 hours. Avoid underdosing early in therapy and consider adjunct inhaled colistin for VAP. So this is one approach which has been used for a long time. Whatever the dose of colistin, half used to be or two-thirds used to be administered injectable form, intravenous route, while half to one-third used to be administered through the nasal form. But this was only true for VAP, and although studies are not equivocal, some studies have shown good result. So what is the impact of RRT on PKD? Intermittent hemodialysis removes most of the hydrophilic antibiotics. So these are the antibiotics which normally remain in the blood. So their dose is increased. Continuous CRRT clearance approximates glomerular filtration rate, that is, which is around 20 to 35 mils per minute. So always the recommendation is give loading dose irrespective of RRT, adjust maintenance dose based on effluent flow, because that ultimately determines. And dose at, as I said, plus ultrafiltrate will give you the total measurement of the effluent. And if TDM is available, then use it, try to use it. So if there is RRT, the adjustment strategy for peptides would include continuous infusion to adjust it to include the effluent rate, meropenem 1 to 2 gram or for prolonged infusion, vancomycin TDM based post-filter dosing, and colistin lower maintenance and loading mandatory. So what is the impact of ECMO on PKPD? Drug sequestration in the circuit tubing and oxygenators may lower the plasma concentration, and therefore these drugs may fail to act. Particularly, this affects the lipophilic protein-bound drugs like linezolid, fluoroquinolones, etc. And in such cases, dose optimization via therapeutic drug monitoring or model-based adjustment becomes essential. So dosing strategies for PKPD optimization with extended or continuous infusion for beta-lactams, we have to maximize time over MIC, and continuous infusion maintains plasma concentration above MIC throughout the dosing interval. This has shown to improve microbiological cure in severe infections with augmented renal clearance. Practical example, you can see a meropenem 2 gram 8 hour day, which is over 30 minutes bolus, is switched to 3 grams loading and then 6 grams over 24 hours as continuous infusion. Whenever we use high dose and once daily aminoglycosides, this maximizes the Cmax by MIC and uses post-antibiotic effect. It also dosing strategies to reduces the nephrotoxicity via the renal recovery time, that it gives renal sufficient time to rest, and as such, therefore, the renal also kidneys also improve their function. Example, amikacin 25 to 30 milligrams per kg IV once daily, and we can monitor the peaks, can keep them between 20 to 40. Now, dosing strategies, if it is a loading dose, critical illness with increases the volume of distribution and delays the targeted treatment, loading doses compensate for this, ensuring a rapid therapeutic response. So we know the loading dose, which I have discussed in the previous slides. The therapeutic drug monitoring, this allows real-time dose refinement to achieve the PK/PD targets while minimizing the toxicity. Indicated for vancomycin, aminoglycosides, beta-lactams, and linezolid and colistin in some centers. There are, in addition, special situations like obesity, where there is an increase in the adipose tissue, giving rise to changes in the volume of distribution. Aminoglycosides, they are used So in case of burns, there is profound hypermetabolism and capillary leak. We know that the inflammatory process is augmented, so there is markedly increased clearance. Aggressive dosing is needed, like meropenem, 2 grams 8 hourly or via continuous infusion. Also in obesity, the beta-lactams also may require higher loading dose, but with aminoglycosides, we have to use adjusted body weight. In the presence of hypoalbuminemia, there is reduced protein binding, increase in the free fraction, increase in the clearance. So for ceftriaxone, free drug may be adequate despite lower total level. So one increase and decrease may balance out each other. Now, role of MIC and resistance prevention. So the knowledge of MIC of the infection pathogen allows PK/PD target calculation for beta-lactams. The target is to give 100% of the times the fraction of that is FT that should remain above the MIC, although this is not possible. So we target 70 to 80% of the time. That is the interval time the drug should be above the MIC level. And the clinical goal would be to maximize the killing action. Aminoglycosides being a concentration-dependent killing, Cmax over MIC more than 10 should be the target ratio with a goal that it is rapid bactericidal. Fluoroquinolones, the area under curve by MIC should be targeted over 125. And with vancomycin, the area under curve by MIC should be targeted above 400, both of which can suppress resistance and also improve MRSA efficacy. Now, this resistance suppression window, I have already discussed that maintaining antibiotic exposure within a range that kills bacteria without promoting resistance subpopulation. So that is the mutant prevention concentration. It is that gap between the two. And we should try to keep the drug above that range when we decide upon its dose for the action. And suboptimal dosing accelerates resistance emergence. So how is PK/PD integrated with antibiotic stewardship? We avoid empirical underdosing or overdosing, minimize resistance development, and always give tailor-made duration and route of therapy. Examples of stewardship action, you can see that ICU therapeutic drug monitoring guided meropenem optimization program reduced the VAP mortality and resistance rates by nearly 25%. So what is the future direction? Future direction is Bayesian forecasting, where software tools like InsightRx, Precise PK, they integrate patient data, PK models, and MIC. All of this can be used to simulate the individualized dosing. Second, population PK models. So this allows estimation for spatial populations like ECMO, CRRT, etc. And bedside decision tools are also opt for the future, where integration of therapeutic drug monitoring, MIC, physiological data into the ICU or EMR systems, they can support dynamic antibiotic optimization. So to summarize, In scenarios like septic shock with high volume of distribution, the problem is of low plasma concentration of antibiotics, and the optimization strategy would be to administer loading dose followed by continuous infusion. Whenever there is augmented renal clearance of more than 130 mL per minute, the problem is enhanced clearance and we have to increase the dose or shorten the interval. With CRRT, drug removal by filter is a problem, and the dose to effluent rate plus therapeutic drug monitoring should be used. In obesity, altered volume of distribution is the problem, and we have to optimize strategy by adjusting the lean or unadjusted body weight. And in hypoalbuminemia, where there is increased free fraction, we have to monitor free drug levels as if they are permissible. So the key takeaways would be that pharmacokinetic and pharmacodynamics are dynamic in ICU patients. Their frequent assessment and adaptation are crucial. Standard doses are often inadequate. Individualized dosing and therapeutic drug monitoring improve outcomes. Continuous infusion of beta lactams, high dose aminoglycosides, and area under curve guided vancomycin represents the best practices that are currently available. Organ support therapies profoundly alter the pharmacokinetics and must guide dose adjustment. And also, integration of PKPD into stewardship enhances both efficacy and resistance control. Thank you.